unfortunately. But I had a beautiful tear today, I think, where they literally torn off the front of supraspinatus, but there were just a few strands left at the front, and I was trying to follow them to see whether they were part of the tendon or part of the ligament, and I meant to go back and try and decipher it because there were all sorts of bits of fiber left, but they were like sort of a spider's web, and I couldn't make sense of it at the time, but I was going to go back over it. So let me.
How much of the time do you find that there's any fibers that remain still attached to the superior facet, as opposed to retracted with the whole footprint?
Yeah, it's supraspinatus goes in lots of different ways, and what you tend to see is either small tears or big tears. I don't get it's almost like they don't come in the middle, you know, because the anterior bundle tends to stay intact in degenerative tears, and you get this breakdown at the back. And then in the traumatic tears, where the arm leaches gets stretched forward, the front gets torn off, but it usually takes the back with it. So they're the one. Sometimes you just see the damage to the front of the tendon. If it's submaximal, just that bit that gets heavily loaded breaks down. You get these partial tears at the front, or sort of almost thinning of the front part. And then, but if you get any more than that, once the front bundle's gone, as that's the strong bundle, you often find the rest of it's gone. And what you've got when people see stuff left, often the bit that's left is actually the top bit of infraspinatus that's coming across the top of it. So that's what I see more than anything else. Now, you're probably not that interested in this bit, but just because you won't have seen them very often before, this is what gallstones in a gallbladder looks like.
Oh my! They're capsulated. The
gallbladder is a little sac. And then
I see. So what I look at as a capsule is the outside of the gallbladder, and there's bright spots inside, and those are gallstones.
Yeah, they're the galls. This is a gallbladder that's very full, so it's full of small stones. So there's almost no fluid at all.
You just went
dirty shadowing behind it.
You just went long and short on it. You did.
There's the long on the gallbladder. There's the short on the gallbladder.
What is that? What is that organ in front of it to the left?
This is all liver. And there's lots of bowel around this, because obviously you've got the liver, you've got the gallbladder, and then you've got all the bowel. So there's lots of air causing lots of funny, difficult to understand sort of things. This is
what is your is this a C2 or C5? What is the
C1 C51? So that's a 5 megahertz to 1 megahertz, and we're probably somewhere in the middle. So it's probably around about 3 megahertz. But can you see that almost like a toy snake?
Yes.
So that's that crinkling in the large bowel. So that crinkle shape.
By large bowel you mean colon?
Yes.
And that's is that gas, or is that just
Yes. That will be air in the colon.
I guess that's the more polite way of saying it.
Yeah, windy pops is as the children do. And this patient had something wrong with his kidneys. So these kidneys are really small. I think we see that's the texture the kidneys should be. Here.
I'd like to have you help me learn how to image the kidney and tell me why I should know it as a therapist. Is there something that you could say, hey, if the person is having, ongoing achy pain after he whatever's, look for this, 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 and this. So you make me just scary.
No, kidneys are just really until you learn, unless you're going to become a sonographer, abdominal sonographer, you don't want to look at them because they are very tricky, and because the bowel wraps around them a lot of the time, and they won't be seen. So it's more of interest rather than looking at you longitudinal. No, it's small. I'm just trying. All right, this might not. You probably can't see this detail on your scanner. This was on an E9, but can you see what that is without reading the thing, or what that might be? Yeah, does that show up on your screen?
Yeah, it show. Oh, at the very top. Yeah, like a sliver, like glass or something.
Yes, it's a bit of a mobile screen.
Say that it's a mobile what?
Yeah, just a fragment of glass from someone's mobile phone.
Oh, wow. But where is it?
It's in the pulp of the finger.
What about that? So give me the specifics on this probe that you're using here.
This is an E9 516 probe. So the classic GE workhorse probe on a reasonably high-end scanner.
If you had $35,000 US, what would you get?
You would for that you could easily get the scanner I normally use.
Is that what you would get, or would you try to go for a refurbished one of these, or
no? I would, at the moment, the best one that we see is it's getting a bit tired. I'm sure there are better ones coming out because it's 5-6 years old at least. But the GE, that's the Logic E that we use, I paid £20,000 for mine, so that must be about presumably a similar sort of price where you are.
And does that come just with the base unit, or do I get a linear and a curvilinear with that?
You should get 2 probes with that price, I would have thought. Mine was an X demo, but that was like 4 years ago. So it's probably, you should be able to get, I would have thought, a new one. It's getting a bit long in the tooth, but this is a big cart machine, but you wouldn't get as good a picture on my scan as you would on this, but you'd be getting close. I'd still expect you to see something like that.
Yeah.
With it.
You said the GE Logic, or was there a number with it?
There's a Logic the Logic E. It's just a letter. Logic E. Yeah. And a reasonably modern one. There've been 2 models of that, so they updated it about 6 years ago. So you can get a lot of secondhand ones that date from before that, but the previous model was not very good.
But you would definitely go with GE.
That's the one I've seen at the moment. Is the best portable that I've tested. It's the one I bought, so I'm slightly prejudiced, but it's a good workhorse. And there are probably some models going that are versions going that are now secondhand. I don't know how long they last. Let's have a look. What else have I got? Data images, Windsor. Yeah, I've got a few of this. There's a nice little AC joint injection I did a few days ago. But
talk me through it, John. You're at AC joint, and you're going to be then going out of plane. Oh no! Now you're.
So I'm in the joint.
Yes.
I'm trying to put stuff in. It's not going in. So that's still capsule. So I'm just checking where I've got my needle tip in short axis. So it looks like it's in the right place. So I'm just going to reposition the needle ever so slightly. There. And then it's going to all go in. And then I'm going to say, That's about right. Oh no, I didn't like my angle. So I've just gone in slightly deeper, and there it is, filling up the joint.
Why would it not go in before? Because you are in the collagen and it's keeping the fluid in the needle?
Yep. So if you look there, when I've injected, do you see where all this area is where the fluid's gone? Yeah?
Yeah.
And it doesn't go above there. So that means that's all capsule.
Wow.
Yeah. So now when we go back, you'll see that when my needle was just a bit lower, just a bit higher, that was where I was before.
Oh.
Not a big difference. You see, I've just come down a fraction of a millimeter.
Yeah, yeah.
The joint.
Wow.
Yeah. And so, but you can't tell that. You can't see it on the image because there isn't enough differentiation. But when you see where I put the fluid goes, you can see all the fluid goes below and none above. So it means that. Are you giving any positive pressure as you're going in so that you feel it release to know when you're in the capsule? Or are you saying? No, I put the needle in, I squeeze. So if you go back to here, where I go in first time, I've gone in, I've tried to inject. You can see the slight probe moves as I'm trying to squeeze here, so it makes my hand wobble. Yes. So nothing goes out. So I don't push harder, because if I push hard, I can dissect the capsule out. Yes. What I do instead is I just check my position, retract the needle, and put in a slightly steeper angle. And I know I don't have to go very much deeper. And then I inject. And I'm in and once you're in the right spot, it should just go, you should just push it out like injecting into a vein or something. How much of it and what are you using? For these joints, I use less than 1 mil volume because they take about 1 mil. So I just put 1 mil in. And I use, typically for one of these joints, I use half a mil of 1% lidocaine and half a mil of depamedrone, which is 20 milligrams of depamedrone. Or if I can get it, the stuff mixed up, which is the same proportion roughly. Is there a brand name for it already mixed up? Yeah, they do depamedrone with lidocaine as an already mixed up one. But these days, sometimes you can't get it. It doesn't have the shelf life. So the companies I work with tend to just buy them too, and you just have to mix them first, which is slightly controversial, but not very. So that was, so that's that. I saw a little cyst. Now, the image is not beautiful on this one, so bear with me. But this is an ATFL, and that's it in short axis. And there's a little cyst actually within it. She's had a rupture of it previously. There's just like a little fluid collection. Now, you're probably less familiar. You're used to seeing ATFLs like this. Yes. Yep, going across there. Yes. But what I like to do is you can't really see that terribly well. There's that fluid. So I've gone into, what I do is I look at these ligaments in short axis. So you spin the probe round on it and you can see the ligament there. So you're coming off the bone here, and that's the short axis of the ligament there. And you off of the fibula, and we're coming to the talus? Yes. And this is ligament here. Yes. And it takes a bit to get your eye in to scan that way, but it's very rewarding when you do it. Yeah, because you really can. Instead of you stop fishing for it and saying, "Oh, it's there," to actually examining it. When you can turn around on one of those ligaments and come down on it, in short axis, then you really know you've seen it and you know you've examined it, as opposed to just going, "Oh, looks like there's something there. It must be intact." There's quite a the fact that there are two heads to the ATFL seems to be quite concerning to some people.
and that one of them is a almost extension of the CFL, and that it can deglove by rolling down and all that kind of stuff. What do you find in real practice or life like that?
In practice, on the scanners that I use, which are not necessarily the super duper top ones, that second bit of the ligament is the tiny, because the bit we normally look at is positioned so it does stretch somewhat. The more distal part of the ligament is a much smaller fragment of it, and it's stiff, so it doesn't fragment. It is very small, and I don't reliably pick it up or even look for it, to be honest. I do like to scan up the CFL in short axis, and then as you pop up onto it, that takes you, as you follow the fibers up, they actually blend not with one part but with both parts, and so that often, once you get into the habit of looking at the ATFL in short axis, you'll find as you ride up, in some patients, you'll automatically ride onto the long axis of the CFL.
I would sure love to have you try to remember to take a little video clip of what your words just said, because I'd like to get my head around that, because I think what you're saying, I know that you have this sono hack of finding the CFL and then showing it as you just drop off of the fibula as the perineal's there. But then when you say short axis, I'm assuming you turn then, and you're actually in long axis on the perineals, and you're coming up onto the fibula, which I would imagine and would then allow you to have long axis ATFL somehow. But I've not played with that, so I would love to see that.
The beauty of it is when you get it, because the CFL is difficult to examine as it goes onto the fibula. In your normal long axis, see, when you're in short axis on your perineals, you come down and you get this sometimes very nice view of the CFL, but you get the bit that's under the tendons and inserting into the calcaneus. What you'd want, if you turn around on that into short axis and get used to scanning that, what happens is that because of the shape of the probe, it's much easier to follow it right up onto the fibula, because the angle you're going at it's much easier to stay reasonably short axis on it. And when you aren't quite right, you get an anisotropic, a dark bit of it, but you can still follow that shape as it comes up. And what you see is the fibers just spread out over the fibula malleolus, a bit like the superficial fibers of the quadriceps, go over the thing. So you get that sense of the fibers blending around the structure, and you see those then follow into the ATFL, and you'll get that sense, not on every ankle, but on some ankles you really get that sense of them all being one structure. So on those big ankles that come in that have been well used by maybe your sportsman or whatever, and if they've got a little bit of fat on their ankles to give you something to angle, you should just be able to ride up over them, and you'll get that sense that you are actually scanning a single structure. But you get it most easy to follow in that short axis on the perineals.
One of the first videos of ankle stuff that I watched from a course 10 years ago when I first started out, it was either Nazarian or Jacobson from over here that basically said, the CFL never gets injured. It gets injured maybe 5% of the time. The one that needs to really be looked at is the ATFL. Now, I am hearing that what they said was that if the ATFL is intact, we can guarantee you your CFL is going to be intact. That the CFL was kind of the throwaway that said only need to look at it if you have pathology in the ATFL. I recently watched a fella. His first name is Bird from Australia. Really good content, for at least from my standpoint. I'm enjoying his stuff.
I enjoy his stuff too.
Yeah, he seems to indicate that the CFL fails mostly from the fibula, and that it rarely will fail down on the calcaneus. And again, I don't know what his credentials are. Is he a sonographer or is he sports med or
No,
do you
he's
know?
a sonographer, but he's a real old timer and done a lot of it.
Yeah, his presentations are really quite unpretentious and very factual, and I've really found him to be splendid to listen to. Anyway, I would love to see you clarify what your words gave me, because that if you ever find a time to just do a quick capture when you can do it on a patient, I would love to see that.
I will do that. This was I never recommend someone sending someone for an ultrasound for the knee, but I get asked to scan. A lot of them come in clinically.
Back up just a second and give me a little bit of the rationale for what you said. What brought you to say I never recommend it?
Yeah, if you're going to do a test for the knee, if you're going to send someone for a test for the knee, you're going to send them for an MRI. Just because unless the question is specifically patellar tendon or specifically one of the collateral ligaments, which is rare, that you don't also want to see what's going on with the
or ACL and that kind of thing.
Yeah, if the chances are there's going to be an intra-articular question with any serious ATFL, serious knee injury. And so if you're going to order a test from somebody, I think it should generally be an MRI, just because by the time you've taken into account their time, your time, and the likelihood of getting a definitive answer, I would always recommend, or I'm very unlikely to recommend, an ultrasound for a knee injury, a potentially intra-articular knee injury.
Let me throw this out for you just because I'd like your feedback on it. Again, this Bird fella, he basically threw onto one of his overlays that if your suprapatellar recess or suprapatellar pouch had 10 millimeters or more, the odds of it being an internal derangement within the knee was like 80%. And then he said if the suprapatellar recess is less than 10 millimeters, he cited a study that said it's 15%. With that in mind, John, would it not be at least some value to be able to do a scan of that pouch and say, what we could tell is that this guy has just walked 2 miles and he's only at, I barely can see biological fluid in the suprapatellar pouch. It's probably not intra-articular, or is that not a reasonable assumption?
I've not seen that paper, but the truth is that it's complicated, and maybe you can say that in a very acute setting, but the truth is that certainly in my practice and in most NHS practice, in UK NHS practice, people don't get to us in that sort of time frame.
Gotcha.
Or their intra-articular injury was 2 or 3 years ago, and they didn't actually do that badly. They tore their meniscus, it didn't bother them. They've done something minor now, and it's bothering them, and lots of things like that. So I think as a screening tool, certainly in our population, it's not a test that you would send someone for. However, I find it extraordinarily useful when patients come to me and they've got a knee problem to be able to look, because there's a lot of, you can do an awful lot of rule in and often you can answer questions that MRI and X-ray don't. And that was a preamble to this next case.
Yes.
I'm just going to see if I can show you. I've just been trying to make up for my lack of things. This case is a lady turns up with what they describe as mild to moderate arthritis, and so in the English system that means she doesn't warrant a knee surgery. But when you look at the arthritis, this osteophyte here is on the anterior femoral condyle, and she can't straighten her knee, and that's her straightening her knee. So even though the X-ray was reported as being only mild to moderate, it's not really seen that the osteophyte is at the front on the femoral condyle, and it's literally blocking her extension. And there's no way that any therapy.
What's the bright thing to the right, John? Is that patella or is that tibia, or what is that?
This is the femur.
Femur. And what's the one on the right?
Condyle, and this is the tibia.
Okay.
So this is anterior medial, anterior knee, but medial to the patella.
Okay.
Yeah, but at the level of the tibial plateau there. So I'm looking at the front of the tibial plateau to the medial to the patella tendon.
Yes.
And as I'm extending her knee, that's what happens.
Wow.
So basically, she comes to us for an injection. The physios have decided that she's got arthritic knee pain. She's not getting her exercise done. She's not straightening her knees. They think it's because of pain. So can we do an injection? So I scan it and I go, no, you can't have an injection. All I'm going to do is take the pain away for 2 days, when you're going to do even more harm as you try and straighten that pain-free leg.
When you're going to do even more harm. So does she get into the queue for a new knee, or what happens here?
Yeah, I just write to the surgeons and I say, moderate OA on X-ray, but dynamic testing on ultrasound shows that she's the large anterior osteophyte is impinging on the tibia and blocking extension. So you're not going to get the extension back any other way other than doing something surgical.
So can you guess how far into extension she was when this approximated?
Yeah, she was about -15, -20.
Okay, wow.
So, wow. I was just holding her leg and just sort of scanning it and just going like this.
Wow.
So she couldn't straighten her knee, and that for me is and that's what I use ultrasound for. As a thing. Yes, I look in at the various tendons and things like that, but I also look at what's actually mechanically causing the problem.
Yeah,
and that can be quite nice. I'm just thinking, I'm gonna see if I can. I've got a scan from today that I'm hoping to find. So you'll have to bear with me, because that was just on the subject of knees. So I might have to flick through a bit.
That's okay. While you're doing that, can you talk at all to echo texture of lymphedema as opposed to just edema, and whether or not you have the ability? They will say if it's cellulitis, it looks like clouds and cobblestone. Is there a signature echo texture for people that have lymphedema?
Let me just have a look. Now, as I say, I have had one or two problems with my my search mechanism on my external hard drives. So if I go edema, and if I go video, no, that's not what we want. Right, this is all that's come up, so it's not searching very well, but I would not necessarily say, I'm just trying to think of if I've got a case of cellulitis, but I think you get both. You get cellulitis produces edema.
What is this labeled here? Is this lymphedema or is this edema or
This is edema. This isn't. I'm not sure there is. I would necessarily expect there to be a difference between lymphedema. I don't see lymphedema patients routinely, so I don't know that, or they don't get sent to me with that label. But this is what edema looks like in the soft tissue. This is lots and lots of fluid in the lymphatic system, and in the soft tissues. This is excessive fluid just round an ankle, and this is fairly normal.
The brighter tissue is adipose, and the darker tissue is fluid around the adipose fibers.
I think that's how it's described. I would be very surprised if it is fluid in the sense that it's tissue with a lot of fluid in it.
Oh, not so much just standing water.
I don't think if you put a tap in there, it would flood out. I'm sure you'd get quite a bit of serous. There will be a lot of serous fluid, but when you push on it, it doesn't move like a liquid.
Yeah. Okay.
You know,
this is.
Sorry?
I did not mean to distract you by what you were doing. I was going to be just asking you if there was a signature thing. In the studies I've looked at, it was the thickness of the skin layer that seems to be the specific differentiation between lymphedema and lipedema, or whatever. And it was supposed to be at about a 0.5% greater. So that in lymphedema, if you simply measured the skin layer, it was supposed to be the differentiation as to what tells that it's. It's after looking at 3 or 4 articles that it said that. So I didn't know whether.
I've never seen any of those articles, but I'd have to say anecdotally that is perfectly true. When there is inflammation there, the skin layer thickens up very markedly, whereas it doesn't quite so much.
It's like leather that's wet.
Yeah, it just thickens. It's just a thicker layer, slightly darker than otherwise, but it depends because and also the fat here isn't very bright. Whereas if you see, let's see what we're doing. If I just put hematoma, deltoid. Sorry. Hematoma. Yeah, no, that's. I was hoping that I would have some subcutaneous hematoma. If you look at the reaction here, this is hematoma. This is not inflammation. But do you see how the fat on this scan? I'll make it bigger. Yeah. Do you see? This is a hematoma here. Do you see how the fat around it has reacted and has become brighter?
Yes.
Fibrotic. That's the sort of change you sometimes see when there's inflammation. The fat becomes brighter, and you see that much more than in that previous case, where with the lymphedema, the fat in between didn't jump out at you, whereas the fat here does. And I say I haven't got one that I've actually got labeled as cellulitis, but you'll see around all these hematomas, the fat around them changes texture and becomes much brighter. That one's not.
That is a physiological response, not a physics response based on the imaging of that area. It's a physiological response as to how the tissue
response. Yes. When you see a bruise someone has bashed their leg, even if there isn't a collection of fluid, you'll see the fat in that area is much brighter. And I sometimes describe that as a diffuse hematoma, but that sort of change is what you see in an infective state as well, because it's the same process, the same inflammatory process is going on.
So what's reflecting back, John? Is it the hard parts of blood?
No, well, perhaps it's I suspect it is fibrosis, because fibers like tendons reflect back. And if you think of, do you remember those games where they had you've got all the skewers go through to make in a puzzle? Yes. Well, if you think of an inflammatory response as being a
lot of fibrin goes in and starts to create this bird's nest type of response.
Yeah, and a bird's nest response of those very highly reflective fibers in all sorts of directions is basically a not as bright as tendon, but a bright tissue that doesn't change, that's non-isotropic, so it doesn't change texture. When you look at a tear, and unfortunately I haven't got it. It was one of those ones that, because what I do when I'm preparing for a tutorial is I store up all my scans on my computer, and then when I've done the tutorial, I put all those scans onto the hard drives, so they then get lost because in amongst the acres of stuff I've got. But yes, I had a scan there where basically, and you must have seen this, where you've got a tear of supraspinatus, but the shape of supraspinatus stays the same, but you just got where the fibers were, you've just got fat. And that's how you tell those apart, because you scan through and you're going, it's not quite right, but it's the right shape for the tendon, so that tendon must be intact. And then you realize that actually there's no anisotropy, and if there's no anisotropy, there's no tendon.
See, to me, that's such quality pearls that I can even envision seeing what I thought to be tendinopathy because of how thick it was, and interesting.
And then you just wangle the probe, and it's and sadly it's all gone. Yeah, so let's see if I can find that knee for you, as it was a good one, and it was today. So is it there? Is that it? Sorry, I'm just going to run it quickly. And no, that wasn't it. No, it was a big old thing. Yes, this is it. Hopefully, this was. Grab it and just move it along. Yes, this was a massive cyst in the thigh muscle, and I'm thinking, I'm hoping I can show you what it is. No, I'm just going to play this video if it's not too long. It's 3 minutes, so I'll run it for a little bit. But you have to take my word for it. Up north here, in the vastus lateralis, is a massive cyst. This is the bottom of a massive cyst in the vastus lateralis. But it tracks down through the side of the knee here, through all this nonsense here, which is soft tissue riddled with little tubes of fluid. It comes down the side of the knee through this sort of what must be a sort of calcified tract of fluid, and there subtly is a tear in the meniscus. So it's a massive cyst that has come out of the lateral meniscus, and I'm hoping that I've got. I haven't looked at these yet.
It does not have it. It's its own Baker's cyst of the lateral meniscus.
But it is, yes. but it's in the vastus lateralis.
Wow.
If I take that back to there, because they called it a ganglion, but it's actually, if you look, it's part of that muscle there. If I let it go from there, it just grows out of the muscle, but it's actually come all the way up through this nonsense here, through all this wriggly tubular stuff, and it comes all the way down over, and it's going there into the knee joint, and you can just about see it. And the tear actually, the fluid just tracks up through there, and you'll just see. I hope you'll get a slice where you can just see the tear in the meniscus there. So yeah, so I saw that today.
Wow.
There you go. See the old dots all the way going through the meniscus?
I do, but this is from my brother who says
there's the split there.
The ultrasound does not have value in diagnosing the knee.
No. No, it doesn't. It has lots of value diagnosing the knee in your hands and in my hands in clinic. But if you're going to go but because the problem with meniscal tears is that those ones that come out of the side, this guy has no knee pain at all and can do everything he wants to do with the knee. He's only bothered by this swelling on the side of his leg.
Whoa!
These tears on the outside of the meniscus that we see so well on ultrasound are not as clinically relevant as the ones we can't see that are deep inside.
Yes, yes. No, I hear you. But what a study, John. This has to be part of your presentation. That is cool.
Oh, yeah. Well, I'll get, as long as I get time to edit it, and I'll chop it down so you just get the good stuff.
What's the calcification? Or what's not calcification, but what's the bright stuff there? It's just debris?
I'm guessing it's just sort of bits of chalky debris. I have no idea. It sort of has some of the appearance of chalk and some of the appearance of air, but it can't be air because he's not sick and it shouldn't be there. So I'm fairly sure in this case it's debris that's a little bit calcified, got a high calcium content, and it's just the little bit of fluid gives it that it's mixed in with, just gives it that sort of slightly ambiguous appearance.
Fascinating.
But, I looked at that and thought, what on earth is going on there?
That is absolutely fascinating.
It made my day. I said to the guy, "Will you get the prize for the most interesting scan of the day?"
What did you do for him?
I stuck a great big needle and took 70 mils of thick, gooey stuff out of that big thing. And,
how many?
And we agreed.
17 or 70 mils?
70.
And it was a gooey, syrupy
syrupy stuff. Yes. So not quite like a ganglion, but certainly what you normally get out of meniscal cysts, because I get asked to drain them semi-regularly.
See, what you just said means nothing to me. Like, not quite like a ganglion, but what you get out, I don't know, have a clue what that is. So you got to use food, because I'm a food eater.
Yeah. So the fluid ganglions have quite a distinctive, really thick content.
Like agar, like a
jelly, yes, but a thick jelly. Whereas the stuff that actually comes out of a joint that's been adulterated by being in the joint, which is what this will have been, that tends to be a little bit slushier, a little bit less clear, but still, it didn't look infected or anything, but it was less perfect.
Wow.
But it was nice, and he understood. He'd had it drained once before. His doctor had drained it and got 90 mils out, so a lot out, and it'd come straight back within a week or two. And I said, well, given because at the time they just thought it was a ganglion, but I said, this isn't a ganglion, it's a meniscal cyst, and it's pretty much bound to come back. But he said, take it out anyway. I'm happy with the small risks. But if it comes back, as it's not hurting my knee, I'll be happy with that. So I took it all out, sent him away.